welcome everyone to our next installment of HIE 101 for Awareness Month this year. Our theme is Hope in Action, and I'm thrilled to, introduce myself. I'm Betsy Pilon, the Executive Director of Hope for HIE, and absolutely marvelous time to welcome Dr. Liz Sewell to join us today to talk about how HIE is diagnosed and what some of the different tools and testing that's done to determine if it is an HIE diagnosis, and kind of talk through the complexity with us to help better understand and have families feel empowered when they're looking through these medical notes, when they're being told different markers and test results for their baby, and what that means for them. So welcome, Liz, to our Q&A.
Well, thank you, Betsy. I'm so happy to be here today with you.
Could you start by giving us an introduction about who you are, what your background is, your clinical and research interests? You and I get a chance to work together through the Newborn Brain Society, and I'm just so thrilled to have you here today.
Yeah, I was born and raised here in Atlanta, Georgia. I did a lot of my training in DC at Children's National, and really a lot of it there focused on the newborn brain. So they have a very strong neonatal neurocritical care program. And a lot of my mentors really were what got me interested. So clinically and research, a lot of my time there was spent on the newborn brain, and particularly with HIE. So when I moved back to Atlanta, I wanted to continue my work with baby brains. And so a lot of my clinical and research focus have really been centered on that. So HIE is, of course, a big part of it. I like the brain because I think it really encompasses so much of who we are and who babies grow up to be. And so for me, that kind of drives my passion. And for HIE in particular, I think it's so sudden and catastrophic and can happen even when everybody's been doing everything right. And so for me, it's just like that personal gut connection, I think, as a doctor and a mother, that I really relate to. Other than that, my husband's Australian, and so we spend a lot of time traveling back and forth. My kids think that's normal, despite me telling them that it absolutely is not normal for people to do that all the time. And I have 3 kids, one of whom spent a little bit of time in our NICU here, actually. So.
Oh. Well, thank you so much for sharing that. And we have families from all over the world. So we have families in Australia as well, who I'm sure will be tuning in. So, and appreciate that there is a connection there as well. So let's walk through kind of the first week of HIE. We know that everything is going great until it isn't. And that, primarily HIE impacts full-term babies or near-term babies. So can you talk a little bit about, let's start out about, how do we get here with diagnosing HIE?
Yeah, I think as neonatologists, we are attending any birth that is considered high risk. And so that can happen for a lot of different reasons. And there are certain things that can happen during pregnancy or at delivery that really increase our suspicion for encephalopathy or for HIE. And we'll probably talk about some of these factors a little bit more later, but they can include things like the baby's heart rate isn't doing well inside mom, or a really big complication at delivery, like blood loss or a problem with the umbilical cord, or a baby needing resuscitation at delivery, or acidosis on some of the blood work. And then probably most importantly is what the baby actually looks like on our exam. And so when we're examining the baby, we're looking to see if the baby is acting like other babies or moving like other babies. And you can imagine that trying to look at the level of consciousness in a baby is a lot harder than older kids and adults, right? Because they can't talk to us. They can't tell us what they're feeling. And so it's hard, and it takes a lot of attention to detail. I think, early on, I think, it's not just one thing that makes us diagnose HIE. It's a lot of different things. And it can be hard, I think, for clinicians to talk to parents about that, especially when there's some uncertainty.
Yeah. And we know that, we've been trying to build this this framework of trying to help families understand and get clarity out there, because we know that this has been published about, it's continuing to be published about, that this is, there's a lot of muddy waters, obviously. And so, we know that at some point, some people started saying that neonatal encephalopathy was the same as HIE. And then some people, were some people say it's an umbrella, under neonatal encephalopathy. And some people don't hear a diagnosis at all, or those terms used, or they might read them in, medical records on their discharge summary or things like that. So, and I know that you work in a site, and like you said, it could be a tent birth, or it could be, some of the hospitals are, children's hospitals in particular, typically have, they're taking on babies that were born somewhere else and get transferred in for therapeutic hypothermia. So what do you know from like those, birth records of the babies that you're trying to put these pieces together, and how that might differ from what you might know of someone where you're getting called into, an emergency C-section, or, a delivery that has a little bit more known risk?
Mhm. Yeah, I think so. So I do work at multiple hospitals here in Atlanta. I work at a delivery center where we have babies born, many deliveries all the time, right? And so there are times where I'm personally at the delivery, but I also work at a referral center where we get calls from hospitals that don't provide cooling and that need some extra support. So I do have we see both of them, both sides of it. I think at a delivery, there are usually things that make us worried, and it's very important for us to share that concern with families. And so what I usually do, the first kind of conversation that I have with families is saying, there's something that happened that made me concerned that your baby was stressed out, during pregnancy or around the time of delivery. And so because of that, we're going to monitor your baby more closely, and that's going to include lots of exams. So we're going to do a lot of exams in these first couple hours, and we'll continue to do those exams, until you go home. So that's usually, I think, one of the first things that I say is just something happened and we're worried. And so because of that, we're going to monitor your baby more closely. I think if during that monitoring you're concerned that the exam is abnormal, then that's kind of the second phase or the second conversation to kind of update the family and share that information. And it's hard, right? It's hard to give bad news, and it's a hard conversation to have, but I think it's our responsibility to be transparent about things and do it in a compassionate way. But I don't think that avoiding naming a diagnosis does the families any favors, in the long run. And so usually I would want to say, your baby isn't acting the same way as many babies. So your baby may not be as alert or as active as other babies. And when that happens, we worry that there may have been a lack of oxygen or blood flow that could have happened at some point during the pregnancy. And if that's the case, we call that hypoxic ischemic encephalopathy, or HIE. So I do think naming that diagnosis is important. And if we aren't sure that it's due to HIE, then I think that's okay. And we can tell families that too. I'll usually say there can be lots of causes for babies to act like this. And we're trying to figure out what the cause was in your baby, and we're trying to gather information. So I think there are different ways to say it depending on the clinical situation, but I do think it's super important early on in that first 24 hours to actually say what we're concerned about.
Really helpful. And so I know a lot of families talk about the SARNAT scale because a lot of physicians will mention that they are, in whether it's mild, moderate, severe, or HIE 1, 2, and 3, which is sometimes what people will refer to it as. What is the SARNAT score? Why is it used? And I know that there's also a lot of people that have been using a modified SARNAT, and why would that be used?
Mm-hmm. So the original SARNAT exam was developed in the 1970s, so quite a little while ago. And it was really used to describe stages of encephalopathy in the first days to weeks of life. So it was over time, and it had 14 elements. It required an EEG. It was not short and fast and sweet. And it was a good tool. But when we started learning more about therapeutic hypothermia or cooling, and we saw in animal models that it may be protective against ongoing brain injury, we needed to find a way to test it in humans. And in order to do those trials and to see if therapeutic hypothermia was effective, we needed a way to quickly identify babies with significant brain injury with HIE. And so that original SARNAT exam needed to be modified. And so this modified SARNAT exam could be done in the first hours of life, not days of life. It was not reliant upon EEG. And it really narrowed kind of the exam components to 6 key domains, and that includes level of consciousness, activity, posture, tone, primitive reflexes, and then autonomic system. And so this modified SARNAT exam really allows clinicians to classify encephalopathy and say if it's mild, moderate, or severe, or in an ideal world, non-existent, right? Which is what we hope for. And in this case, a higher number correlates with a more severe stage of encephalopathy. And so when clinicians are trying to determine eligibility for cooling, it is helpful to be able to quickly and accurately classify the stage of encephalopathy. And there have been studies showing that this has been validated, and so it can be standardized across different groups and different people.
Really helpful. And I think, the question that comes up, and then, a lot of people, I think the educational materials and how families are being told about things has changed over the past, decade plus, which is wonderful to see and has improved a lot. And so I think it's important for families to know too. And I'd love to hear your take on this of, like how the SARNAT scale is not necessarily indicative of what that outcome is going to be, that it's used for that moment in time to drive treatment decisions and kind of give that categorization of like kind of how sick the baby is.
Mm-hmm. Yeah, it is, it is an assessment at one point in time. What I tell our group is that it can change and it's variable. And so I don't go and lay hands on any baby one time and say, this is it. I will stand there and teach people and talk. And all that time I'm looking at the baby and making that assessment. So, at a minimum, I'm there for 5 or 10 minutes at a time, and I'm there multiple times throughout the day. The other thing that we know is that, encephalopathy changes over time, and that trajectory is really important. And we know that cooling or therapeutic hypothermia can change that trajectory. So just because a patient may have a severe SARNAT score, in the beginning before cooling has started, doesn't mean that that is always going to be the case. And so what we hope to see is that cooling modifies that exam, and we continue to see that exam get better during cooling, and ideally maybe even normalize before going home. And so to me, I think the trajectory and how it changes is much more important than that initial exam, early in the beginning. The other thing is that exam only tells us what we can see from the outside in, right? And so it's only one piece. It doesn't tell us what the brain looks like on the inside or how the brain is functioning. And that's where additional tools can be helpful.
That's really helpful to hear. So let's go into APGAR scores. This is like, I know, right at birth when we're talking about timing. What are APGAR scores and why are they used and important?
Yeah, the APGAR score is just a quick standardized method to tell us how a baby is doing immediately after birth. And so it evaluates 5 criteria on a scale of 0 to 2. So heart rate, breathing, color, grimace, and tone. And so the total score can vary from 0 to 10, with a higher score showing a better physical condition, right? So a 10 is a perfect score. Very rare for any baby to get a perfect score. And we generally give this score at 1 and 5 minutes of life, and then we can continue to do it more after that if the baby is needing resuscitation. So the score is kind of a quick standardized assessment. It can be used to guide resuscitation and to tell you what intervention should be done next and how the baby responds to that. But it's not alone a good diagnosis tool for HIE, and it certainly alone doesn't predict outcomes. So we have plenty of babies that may have a score even of 0 initially that go on and do quite well.
Really helpful. And then as another marker, families will see in the blood work, blood gases done. And so can you talk a little bit about what those are, why those are used? And, I guess, there's a couple of different components within blood gases. So, if you could talk about like arterial and pH and the base excess and all of that stuff.
So blood gases are really common in medicine, right? We do them in babies, we do them in adults. And a lot of times blood gases are used to talk about how a baby is breathing, but it can also be used to talk about how the body is using oxygen. And so with HIE in particular, probably what we talk about the most is that first cord gas or that first blood gas. And most of the time we get that off the umbilical cord. So remember that the umbilical cord is what carries oxygen and blood from mom's placenta to the baby. Okay, so that is the baby's life source. And if at any time there is a problem with oxygen or blood flow to the baby, that is going to be reflected in the cord gas. And so the cord gas, the two components we're going to look at the most are the pH and the base deficit. And what we want to do is see if there is a buildup of acid in the body. If there's a problem with oxygen or blood flow to the baby, there's going to be a buildup of acid. Okay. And so if there's acidosis, which would be seen with a low pH or a high base deficit, then that's a sign that maybe the baby was not getting enough oxygen and blood flow. And usually it suggests an acute process. Okay, so something that's happening near the time of delivery. So if there's no acidosis, it doesn't mean necessarily that the baby doesn't have HIE. It just means that it may have happened more remotely. And this is really important for us because we know that cooling is most effective when it started close to the time of injury. So if there's acidosis on that cord gas, then it makes us think that something may have happened more acutely and cooling is going to be most effective. Again, if there's no acidosis, it doesn't mean that the baby doesn't have HIE or doesn't have injury. It just may mean that cooling may not work quite as well. The other thing I think is that sometimes there are situations where we cannot get a cord gas. Maybe we can't get blood from the umbilical cord. And in that case, we may substitute a gas from the baby, close to birth. And so sometimes you'll see both.
Really helpful to learn more about. So let's move into, you talked a little bit about the clinical picture as you're looking at things. And so, what are some of, as babies and families travel through this with you, what are some of the things that you're looking at to help guide you in towards a confirmed or ruled out diagnosis of HIE?
I think a lot of it starts at delivery with the blood gas and whether or not there was what we call a sentinel event, some kind of complication during delivery. And if either of those two things happen, it makes me kind of pay a little bit more attention. I know that I need to do a very detailed exam on this baby to try to see if they have encephalopathy. Not every baby with acidosis or every baby that had a complication at delivery develops HIE. And I think that's really important, but it is our responsibility as clinicians to check, right? We have to go look and find out, because if we don't look, we're never going to know. So not all babies have that. Some babies may have abnormalities on exam that are milder and don't meet criteria for therapeutic hypothermia. And that's important to know too, right? It is still really important that all of those babies get follow-up, because we know that babies, even with mild abnormalities, are going to be at increased risk for delays later in life. And, we know that encephalopathy can change over time. So over the last couple of years, our center has started doing serial exams, even on babies with mild encephalopathy. And most babies actually do go on to normalize their exam and continue to do better. But there is a small percentage of babies whose exams get worse. And that's important for us to know, because that's going to change our management. And we want to make sure that we offer the best treatment available to every qualifying baby. And that includes the babies that were initially mild and then develop more severe exams. So I think there are things that make us pay more attention. And a lot of the time that's going to be a cord gas acidosis, or a complication at delivery, or maybe the baby just isn't acting as alert as usual, right? So if any of those things happen, then we start doing more detailed assessments and looking for other things in the medical record and the history.
Yeah. So I think this leads a little bit into talking about neonatal seizures, because this is one of the markers that I know is one. HIE is the most common cause of neonatal seizures. I know you've done a ton of work in your own center about, anti-seizure medication discontinuation and like all the hot topics that we love to improve care for babies and families. And you're the site lead for the Cool Prime trial. So which is for mild encephalopathy and looking at, is cooling effective or not. And so that it's been really interesting being on the behind the scenes end of that and learning more about the screening process that you just mentioned for this, and how many babies are having subclinical seizures that are actually not mild. And so when we talk about neonatal seizures, I think, that's a question that comes up with families a lot, because, we'll also have a cohort of families whose babies will seize like 12 to 24 hours later. They might have had good APGAR scores and a good cord blood gas, and then they do imaging and, and the kids are seizing, and they ended up, that this is like a delayed onset of symptoms and have HIE from some causation. So can you talk a little bit more about managing those seizures and that discovery process, and I mean, highlight the great work that you've done as well to improve that care for families along the way too?
Yeah, I think, seizures are hard because they're so much harder to diagnose in babies than they are in older kids and adults. So I think when people without any experience or exposure to it think about seizures, what they think about is that classic jerking movement, that we often see in adults, and that is so uncommon in babies. So um, we are, as clinicians, we can both underdiagnose seizures and miss them because they don't have classic clinical symptoms. And then we also overdiagnose them and treat movements that aren't seizures and unnecessarily expose people or babies to medicines that have potential side effects. And so it is really hard to diagnose seizures just clinically with our eyes. And so what we've learned over time is that we really, in order to accurately diagnose them in babies, we really need to have them on neuromonitoring. And the gold standard for that is a continuous EEG, which is what we use in our centers. There's also something called an amplitude integrated EEG, which is similar but less leads. And so, it kind of compresses them, but is easier to interpret at the bedside. But really, the standard of care is to do one or the other for that. And as you mentioned, because HIE is the most common cause of seizures in babies, we know the recommendations right now are really to empirically monitor all babies with HIE. And so, at our center, every baby that gets cooled is going to empirically go on one of these monitors from the beginning as soon as we can get it on, and at least until they are rewarmed and done with cooling and their seizures have resolved. And that's so important. We want to know if there's seizures, we want to treat it early, and we want to get them under control. On the flip side, we don't want to continue medicines on babies that don't need it. So we know that babies with HIE are at higher risk for epilepsy than the general population, but really most babies with HIE don't develop epilepsy. So it's usually the seizures are short and really due to this acute brain injury. And so what we want to do is try to get them off medicine that they don't need anymore. And so that was a really big focus of our work here at Emory and Children's. When I started here, probably about 80% of our babies were going home on anticonvulsants, and it, that could be weeks or months until they're starting to wean off. So that's a lot of medicine. And so we have worked together with our colleagues in neurology really hard to try to make sure that we are very much trying to come off of it. And sometimes it doesn't work, but a lot of the times it does. And so we've been very successful at trying to reduce our babies and families that are sent home with this medicine. I think it's important that families are educated, though, on what to do if a seizure happens, whether they're on seizure medicine or not at discharge. We want them to feel empowered and know and prepared and know what to do. And it's also certainly important that they have follow-up with a pediatric neurologist as well.
Yeah, definitely. That's one of the things that we, obviously have seen over the year. This has been such a, my kiddo is almost 13, which is crazy. And, to see this change, I was one of those parents that we got discharged on phenobarbital. There was never any noted subclinical seizures or clinical seizures in his course. He was dosed early and heavily with phenobarb. And, as a parent, you never want your kid on unnecessary medication. And I was like, when do we know? Like, do we need to do another EEG? When can we take him off of this stuff?
Mm-hmm.
And his neurologist was very hesitant, and his pediatrician was less hesitant. And so, around 3 months is when we weaned. But now to see that the evidence is there that, supports, so, there's like a algorithm almost now of who
Mhm.
uh, can come off of it early, who might need to stay on it. And then, even if seizures develop outside of the NICU, the baby at least would have, a break from the medication, because there is
Mhm.
no like, it doesn't prevent the onset of seizures for, necessarily keeping them on it if, seizures show up at 6, 12 months. And so that's a huge area of improvement, over the past decade.
Mhm. Mhm.
And I know that, you've really done the work to implement that change as a quality effort.
Mhm. Yeah, I mean, I think it's really fascinating how much it varies by center, right?
Mhm.
When we looked in the Neonatal Research Network, it was like a vast difference. Some centers were hardly ever sending babies home with it, and some centers were sending every baby home with it, and they've showed that in the neonatal seizure registry as well.
Yeah.
And so, for me, changing centers, it was the contrast was quite apparent, and we were working on it. But I really do think the work from the neonatal seizure registry, and I know you guys were part of that kind of effort as well, but I really think it gave us more, I don't know, evidence to really push harder for it, and it got us more buy-in. But it is hard to change culture, right? If
Mhm.
somebody for years has been sending babies home on anticonvulsants, it's hard to change culture, and it takes time. And so a lot of conversations too.
Definitely, definitely. All right. So as we're working through the NICU course here, we talked about MRI in a previous Q&A, and we talked a little about EEG and the importance with this in this conversation. So I'd like to move forward of, through the NICU course and how you kind of know when a baby is ready to be discharged.
Mhm. That's the most important question for any parent, right? Every parent asks at some point, when can my baby go home? And I think in general in the NICU, it's three things that we're usually thinking about. So can my baby stay warm on their own? Can the baby eat on their own? And can the baby breathe on their own? And that's still true for babies with HIE, right? We want babies with HIE to do those same things. From my experience, most of the time babies stay in the hospital if they have HIE because they're having difficulty taking all of their feeds by mouth. So that is the most common reason why babies are still there. But most babies do ultimately, with time, take their feeds by mouth. Sometimes they need to go home with a feeding tube, and we would talk to the family about that. Most babies with HIE can hold their temperature, and most babies with HIE can breathe on their own, although sometimes they may need help with suctioning, if they're having difficulty with secretions. And maybe in severe cases, some babies go home on a ventilator. But I think, when we're thinking about discharge, if a baby can eat on their own, breathe on their own, stay warm on their own, they're pretty close to going home. If over time a baby's having difficulty with any one of those things, then that's really where we want to work with the family and talk to the family about the best path forward, for a safe discharge. And in some cases, that can mean additional equipment
Mhm.
potentially. And that's something we want to make sure is a shared decision and that the family's on board with. And of course, if we're going to send a baby home with additional equipment, then there's a lot of extra training and education for the family before they go home.
Yeah, that's really helpful to hear, and get that guidance. How do you help prepare HIE families for discharge? And what, we always talk about, I think overall in NICU care, that, there's this cliff that people feel when they're discharged and get home. So how are you helping to prepare them?
Yeah, I think having ongoing conversations with them throughout the hospital stay is so important. We don't want to just drop this bomb, right? This diagnosis on them and say, peace out, good luck. We want to be talking to them throughout the stay. And that's important because one, we're gathering more information over time and it changes things, right? And hopefully we're getting more information. And also just because I think repetition is helpful for families understanding. And I think as we get to know the baby and as we get to know the family a little bit more, we have a little bit more idea of what they may expect after discharge. The other thing is, I don't, as a neonatologist, I don't personally work in follow up. And so I'm not going to be the same doctor that they're seeing afterwards. And that can
Mhm.
be hard, especially if you've gotten very close to the family. And so talking to them about what their resources are going to be after discharge. I think you guys have done such a great job. I love hope. And so I give my parents homework assignments. And sometimes I'll sit there at the bedside and say, you need to register for this. You need to reach out for this. This is your support system. I can tell you about HIE as a doctor, but I can't tell you about what it's like to parent a child with HIE. You need some peer support. And so sometimes I'll even sit there at the bedside while they register online and try to make that connection. I also really emphasize the importance of follow-up. And so, I think we have some families who are like, my baby's doing great. There's no problems. I don't need follow-up. And that, I understand where that's coming from. But it's not the right answer. And so I really try to emphasize with families, what resources they're going to have after they go home. They have their pediatrician, they have hope, but they also really need the follow-up clinic and why that's so important.
So what does follow-up look like for your community and the different hospitals that you work with?
So in Georgia, we are divided into 6 different perinatal regions. And so the metro Atlanta area is probably the largest region, and each region has their own follow-up center. We are very fortunate here in Atlanta that our follow-up center sees children up to age 5. And so that's more robust, than a lot of centers. We refer any baby with a diagnosis of encephalopathy or HIE for follow-up. So every baby, regardless of whether or not they get treated with cooling, is going to have follow-up. It's a multidisciplinary follow-up clinic. So we have PT, we have speech, we have all of these places, all of these people and resources coming together to try to evaluate the babies and make sure that they're getting the best interventions that we have available. So for me as a neonatologist, I think the most important thing that I can do is to emphasize the importance of follow-up. That first follow-up visit, even if your kid's doing well, even if they're not having any delays, but letting them know, the importance of it, right? And so we know that if we do find any kind of delay, we know that early identification and early intervention, those kids have better outcomes. And so that's why it is so, so important. The other thing that I like to talk to parents about is that we have an abundance of evidence that parent involvement and parent participation can change outcomes. And so I tell them that they're going to have a much bigger impact on their child's life, throughout the course of their life than I will have had just in their short NICU stay. And so to me, I think that's empowering for families to hear, and important for them to know.
Yeah. Yeah. And I think sometimes that gets lost in the shuffle because they get thrown into this like therapy world. And then it's like, need more therapy, let's do all the therapy all the time. And then the research shows that a lot of times the environmental impact of reading to the baby and child as they're growing and giving them multisensory experiences. I remember our neonatologist saying, put your baby in the grass, have them feel the grass around them and sand and, birds chirping, sunlight, all these things, and just making family memories. And there is a lot that is neuroprotective in that, and that we have some really good research that shows the impact to positive neuroplasticity and brain development with that environment.
Yeah, and I think, Reach Out and Read is a popular program here in the US, in pediatricians' offices. We are actually, our NICU was the first NICU, and maybe still is the only NICU, to actually be a certified Reach Out and Read. So we have books in the NICU for families to read to the babies. Every baby, when they go home, goes home with their little stack of books. And so I agree. It's so important, and it's so wonderful to see when we have families at the bedside reading to their babies. Absolutely agree.
Love it. So as we're moving to the end part of this, which I've loved this conversation so much, and it's been so helpful, I know, for families that have been tuning in. What's your big takeaway that you want for families to know the most about, HIE and facing this complication?
Yeah, I think one of the things that I try to convey early on is that it's not their fault. I don't know, as a doctor, as a mother, I feel like as moms, we put so much blame on ourselves and we carry the weight of so much guilt. And so I have so many moms that say, but what if I had done this, and what if I had done that? And I think it's important for them to know that this didn't happen because they did or didn't do something because of something they ate. Like, it's just an awful known complication that can happen at birth. And so that's really the first thing that I don't know, I'm always saying to moms is, you didn't make this happen. The other thing I think is that they're not alone. So their clinical team, we're here to support them on the journey, to care for their baby, to answer questions, and that they're really an important, probably the most important part of the care team there in the NICU. And then again, Hope is a great community. So as a doctor, I care for a lot of babies with HIE, but I'm not a parent to a child with HIE, and I can't tell them what it's like to live that journey. And so that's why I love Hope, is because I think it's such a great resource, and to let them know that they're not alone.
Thank you so much for sharing that. And what are your hopes for the future for HIE and the kind of the state of where things are and where they're going? What do you see as
I
next?
would love a world without HIE, right? That's the goal.
Our goal is to be out of business, right?
Yeah. That is the goal. I think, part of where I would love to see this go is better healthcare in general for women, for pregnant women. I think if we can take better care of women, we would see less HIE, but it wouldn't be non-existent. And so I think trying to find more therapies, and that can include things in the NICU, complements to HIE. We had a lot of hope for EPO, and unfortunately that didn't in the way that we wanted it to, but there are other therapies out there that seem promising. And so I'm really looking forward to seeing how that evolves. And then there are lots of babies that right now don't meet criteria for cooling. And so I think, in that case, trying to find a new therapy would be wonderful. The other thing is that, at least here in the US, we have variable resources after discharge, and it varies by state, and people have different access to care. And so I think increasing the access that people have to those early interventions would be great too.
Yeah, I think it's interesting when people look at the US, and especially, I know you do, we work with a lot of people all over the world when we're working together through the Newborn Brain Society and, in other circles. And, there's a perception of obviously our country's healthcare, there's so many big opinions about where it is and where it's been and where it should go. But I think what's lost sometimes is that, and I know you experienced this, I've driven through Georgia multiple times, and live in Michigan, where, we have a huge rural disparity, and we talk about maternal care deserts and child care deserts and things like that. And that's reality, when you have people, I've known families that are in northern Michigan that, in the winter, if they're delivering a baby and, there's a snowstorm, you're changing from being able to do a life flight via helicopter, which is impossible, to then looking at how you're going to get an ambulance to a cooling center. It's that rural disparity. And I know, Georgia is the same of, not just, in follow-up care and things like that, but it's really, I think people forget that even though it seems like we're a highly populated country, that we have so many, so much rural space as well.
Yeah, I think Georgia is unique in that it has the different perinatal regions. And so that has, that started way long before I was practicing, but I think it was an attempt to try to address some of those disparities so that every region in Georgia had a center that was capable of cooling or, other things for high-risk babies. And so trying to make sure that we have a point person, but disparities still do exist, right? And that's part of the work we're trying to do.
Definitely. Well, wow. Thank you so much for all of this important work and fun conversation today. And just, I know when we do these Q&As, it's so helpful for our families to just, take a moment and pause and really think through and learn, especially families who are just starting the journey, and they're trying to weed through what the heck has happened and what all
1,000 pages in the medical chart. Yeah.
what all these acronyms mean, it's like learning a different language. And so conversations like this are so impactful. This is going to turn into a blog post and some social media squares and things like that for some key takeaways. And so I just want to thank you so much for your time today, for all the work that you do in the care that you provide for families, and then in your work in research and advocacy and all things. It's just a wonderful opportunity to work together and to see the impact that you have on so many people and so many families in your care and otherwise. So
Well, thank you, Betsy. No, it's my pleasure. I love working with you personally, and I love Hope. And so any chance that I have to work together and collaborate, I'm always down.
Awesome. For families that have been tuning in today, thank you. As always, we love to continue the conversation. So if you've been commenting, if you've been submitting questions, we will take those back and work on addressing those and building. We're always working on building more educational resources. This will be an evergreen resource on our YouTube channel and across social media. So you can go back to it at any time, listen to it, watch it, whatever you want to do. And so we'll look forward to the next one. And thank you again, Liz, for joining us.
My pleasure.
All right. Take care, everyone.
Bye-bye.